discussing about is about bifurcation stenting in coronary artery disease. As all of us know that coronary artery disease is the most fatal as well as the most common cause for death, especially in Southeast Asia, but in India, because India is the diabetic capital of the world. So the coronary artery disease is more rampant in our countries. So at the same time, the disease pattern like diffuse disease, more malignant disease, involvement of the left main as well as the bifurcation. Disease involving the side branch also is more common, we see it more commonly. So as it is, mine is a single center, single operator center. So even though the load is not much high, maybe operating 10 to 20 cases of angioplasties per month. Almost 20 to 30% of these patients usually have complex coronary artery disease, including the bifurcation lesions. So when compared to the bifurcation, actually it is either left main bifurcation or non-left main bifurcation. That is diagonal or L-shapes and Y bifurcation stentings. So if we consider the stenting strategies in bifurcation, or most commonly which we use is the provisional stenting. That is main vessel only stenting remains the major stenting strategy in these scenarios, because the side branch disease, which whether we have to go for an upfront bifurcation stenting strategy or we have to decide after provisional stenting, it all based upon the patient characteristics as well as the anatomy and how important is the side branch. That is the size of the vessel, the territory that side branch supplies, and the hemodynamic or other clinical or symptoms that the side branch will produce. There are various factors based on which we will decide if the side branch has to be stented or not. So provisional stenting remains the cornerstone of any bifurcation stenting strategy. And the stents now, because of the modern design, the stents which we are using now, because there has been a lot of improvement in the engineering of the designing of the stents, that is open cell design. There will be very minimal struts or the interconnectors which will be blocking the side branch. So with these advanced designs, the risk of side branch closure has been reduced even in provisional stenting strategy also. But and also the strut thickness. As the strut thickness comes down, the chance of side branch closure also comes down, because if we see 80 to 100 micron struts, it may get close or narrow the vessel. But if we see 60 to 70 microns thickness, the chance of occluding a side branch even with provisional stenting also very less. So let us consider if provisional stenting is not the upfront strategy. If we consider that side branch is very much significant, ostium of the side branch is disease and it also requires stenting, then we will go for the upfront bifurcation stenting strategy. Then there are so many bifurcation stenting strategies, either like Cullard, mini Cullard, DK crush. So it all depends upon the operator, which the procedure which he is very much well versed with, or sometimes the coronary artery anatomy also the side branch strategy has to be followed. Usually I do mini or nano crush stenting technique in bifurcation stenting. In this, the side branch vessel and main branch vessel are wide both simultaneously. Then predilatation is done as per the size of the distal vessel. Then side branch stent is placed first, then it is deployed with 2 to 3 mm protruding into the main vessel. Then the balloon and the wire is removed out. Now main vessel stent is deployed, crushing the side branch stent, followed by rewiring of the side branch, then kissing balloon dilatation, followed by the proximal optimization of the main vessel stenting. This is the usual strategy which I follow in my cath lab. I did almost 2-3 cases in this month itself. With good results in this. The stent which now I use is very comfortable for me, because recrossing of the wires, recrossing of the balloons, it all depends upon the profile of the stent and the stent thickness and the open cell design. So all these things are very helpful in bifurcation stenting strategies. At the same time, the trackability, the radial strength of the struts stent design is also very much important, because if we're going for mid or distal LAD lesions which are having sometimes tortuous vessels, then we may need a stent which is more flexible and trackable so as to reach those locations very easily. At the same time, without compromising the side branch. Then coming to the outcomes or expectations, what is a good result for side branch stenting? Even for suppose with provisional stenting we have done, if there is a good TIMI3 flow, even though side branch ostium appears to be pinched, if there is distal flow is very good, no hemodynamic changes, no clinical changes, then it is a optimal result. We can accept the result and there is no need for any bifurcation strategy. For suppose if we opted for a dedicated bifurcation strategy like DK crush or mini crush, which I have done. So it again the side branch flows, TIMI3 or TIMI2 or TIMI3 flow. At the same time, the ostium of the side branch, the final kissing balloon dilatation is very much important. It should be done so as to prevent the restenosis risk in the side branch. So, if we see the clinical experience, the scientific data which encourages us, this is the as for now, till now, with the available data, provisional stenting is always the best strategy, provided if there is no side branch, significant side branch compromise. So only stenting the main vessel. Now, as I told, with the advanced stent design, the chance of side branch occlusion, even if the side branch ostium is also deceased, is very much less, as I told, because of the strut thickness, which is very small, almost 60 microns now we are getting. Open cell design, there are not much interconnected leaks even within the main vessel stents. So there the chance of stent struts coming across the side branch is also very less. So provisional stenting remains the best. Then if we take bifurcation stenting strategies, DK crush is the most well studied and the results are very much good with the DK crush stenting strategies.